Good afternoon, dear audience. I'm going to talk about the 6 months progress of my research work on the diagnostic and therapeutic options in sepsis and trauma-associated coagulopathy. My name is Tímea Mátyási-Dombi. I'm a first-year PhD student and specialist in anesthesia and intensive care, currently working in Manningerjenő Trauma Center, Budapest. My vision is to see efficient hemostasis management worldwide. Therefore, I would like to improve personalized hemostasis management for critically ill patients. I have 2 ongoing projects currently. Both of them use the method of meta-analysis. The first one is about the efficacy and safety profile of thrombomodulin in sepsis-associated coagulopathy. The dysregulated immune response in sepsis leads to the disbalance of hemostasis, causing microthrombi, different organ failures, and even death. Sepsis-induced coagulopathy's prevalence is about 50%, with a very high mortality. Thrombomodulin is an anticoagulant agent with an anti-inflammatory and antifibrinolytic activity as well, so it could be used as a potential therapy in sepsis. The lacking evidence of the efficacy of thrombomodulin is because of the different target cohorts and diagnostic criteria in RCTs. However, recent studies show that thrombomodulin is more effective for patients with septic coagulopathy and high disease severity. The guidelines, the international and Japanese ones, are controversial. So we would like to investigate the potential benefit of thrombomodulin in different subgroups of sepsis-associated patients. We raised the clinical question: does thrombomodulin therapy improve the survival rate of patients with sepsis-associated coagulopathy? We want to compare thrombomodulin therapy versus standard of care in SAC patients. And we investigate mortality, outcome, and different secondary clinical outcomes as well. We hypothesize that thrombomodulin administration can improve survival in any of the patient subgroups in SAC patients. We registered Prospero and done a systematic search in the 5 main databases. After selection process, we have 34 eligible articles. And we have finished the analysis of the primary outcomes and waiting for the results of the secondary outcomes. The first outcome is 28-day mortality measured in odds ratio. If the odds ratio is lower than 1, it means that the mortality is lower with the intervention. If it's higher than 1, it means the mortality is higher with the intervention. We have analyzed 21 studies with around 8,500 patients. We had non-randomized propensity score-matched studies and RCTs as well. We analyzed them together and separately as well. The heterogeneity is 62% in the overall population, which is high, and the reason for it is the heterogeneity of coagulopathy, the different sources of infections, and concomitant treatment. The overall effect of thrombomodulin is 0.65, which means that the odds ratio of death decreased by 1/3. It is really huge. It has a really huge clinical relevance, and it is mathematically significant as well. However, we have to mention that the propensity score-matched studies and RCTs show the same tendency, but they are not. If we analyze them separately, they are not mathematically significant, but the tendency is strong. Secondly, we analyzed ICU mortality, and results are shocking because in these 3 studies we have around 600 patients, and the mortality, the odds ratio of mortality is 0.51, which is really good because we have decreased to almost half the ICU mortality. It is not just clinically relevant, but statistically significant as well. Lastly, I would like to show the results of in-hospital mortality. We had 7 studies and around 8,000 patients with the same measures. There were non-randomized and propensity score mesh studies. We have also the overall effect 0.76, which means the in-hospital mortality, the odds ratio of in-hospital mortality decreased by 1/4, almost 1/4. It has a high clinical relevance, but it is not almost clinically significant. Our studies' strengths are that RCTs and non-randomized studies were evaluated separately as well, and we had lots of patients, more than 8,000 patients for analysis. However, the mostly Japanese studies, the potential overlap of the patients in registry analysis limit our results. So our preliminary conclusion is that thrombomodulin reduced mortality in SAC, but we have to refine the indications for its use. And that's why we want to make further subgroup analysis. And for further studies, we have to evaluate thrombomodulin on more homogeneous populations based on infection source and pathogen and other things as well. We have finished data extraction and waiting for the results of the secondary outcomes. My second ongoing project is investigating the efficacy and safety of early fibrinogen supplementation in patients with severe trauma. It also uses the method of meta-analysis. Trauma-associated hemorrhage accounts for 40% of all trauma deaths. There is trauma-induced coagulopathy. Its prevalence is around 30%, and both the consumption of fibrinogen and increased fibrinolysis leads to the rapid loss of fibrinogen, which is an independent predictor of death because it also causes different organ dysfunctions and after that death. Fibrinogen level should be maintained about 1.5 gram per liters in severe trauma patients, according to the European 2023 guideline. Fibrinogen concentrate is widely used in traumatic hemorrhagic shock. We can even give it in the trauma field or in the ambulance, but we don't know exactly how much is ideal and the exact time point. That's why we want to investigate the very early, the early benefit of early administration of fibrinogen administration in severe trauma patients. So we raised this clinical question: does early administration of fibrinogen improve survival in severe trauma patients? We compared early fibrinogen supplementation versus placebo in severe trauma patients, and we would like to examine mortality, bleeding requirements, transfusion, bleeding risk, transfusion requirements, and other clinical parameters as well. We hypothesized that administration of fibrinogen in trauma-induced coagulopathy may improve survival and lead to better clinical outcomes. This is our preliminary research strategy with a few thousand articles. We are checking the topic's feasibility and want to continue with Prospero. In summary, I have these 2 ongoing projects, and I would like to finish the first one by the end of this year. I would like to thank you for your attention with the words of our famous painter, Tivadar Csontváry Koszka. Every person needs a broader perspective to see more and to be aware of the divine nature. In a broader perspective, we find a new perspective. In a new perspective, we find a new life. Thank you for your attention.
Thank you very much, Tímea. You presented quite impressive results regarding the 28-day mortality and thrombomodulin implementation, and I'm just interested in the ICU survival rate, which is more impressive, but for how long did they stay on ICU?
I have checked the studies. Unfortunately, they are not reported like that. Just some indirect information is written in the articles. For example, ventilator 3 days and ICU 3 days, which means that the ICU mortality is less than 28-day time frame. It is a less than 28-day time frame. And we have to mention also that in this study, these are just 3 studies and propensity score measured. They include 28-day mortality as well, but not, for example, in hospital mortality. So they are not the exact same studies what we used for analysis in the different outcomes.
I have also checked our results in Kiskunhalas from last year, and I can tell you that the average ICU stay for infective patients were 4.5 days, much less than 28.
Yeah.
Congratulations to your presentation. I have one question in connection with your first topic. According to your results, thrombomodulin seems very beneficial. I'm just curious if you are also using this in the clinical practice or not.
Unfortunately, we can't use it in Hungary because it is not, we can't find it on the market in Hungary, unfortunately.
Thank you.
Congratulations on your presentation. I would like also to ask a question about your first project. You mentioned that the further research implication is the source of infection. What was the source of sepsis in your included articles?
There were articles where there were multiple sources of infections, pulmonary, abdominal, urinary, and all the others. And there were some studies where it was quite homogeneous, just pulmonary or just abdominal infections, for example. The most homogeneous articles were mostly about abdominal infections.
And are there enough articles for subgroup analysis based on the source of infection?
We are checking it. Yes.
Thank you.
Thank you very much. Can you just name a few of the most important factors that the propensity score match studies matched for? Because maybe these are the indications actually for thrombomodulin, and that would mean the difference between observational and propensity score match studies.
There were studies with about 10, 15 factors like age, sex, comorbidities, and things like and organ dysfunctions and like that. The coagulopathy, for example, the severity of coagulopathy. So they really matched the patients. Yeah, but they used different factors in the different studies.
Thank you.
Yeah.